Hey everyone, welcome back to the channel. If you're studying for your FNP boards, you know how daunting the neurology section can be. It's this incredibly complex system, and the exam questions can feel like they're coming out of left field. But here's the thing, you don't need to be a neurosurgeon to ace this section. You just need a solid, practical understanding of the fundamentals and how they apply to the real world of primary care. My goal today is to break it all down for you, to connect the dots between the textbook knowledge and what you'll actually see in your clinic. We're going to dive deep into the neurological exam, making it feel less like a checklist and more like a conversation with your patient's nervous system. We'll walk through the cranial nerves, not just memorizing them, but understanding what they do and what it means when they're not working right. From there, we'll tackle some of the heavy hitters you're guaranteed to encounter, both on the exam and in your future practice. We're talking Bell's palsy, dementia, those tricky headaches, Parkinson's, strokes, and a few others. For each condition, we'll cover the need-to-know info, how to diagnose it, the latest treatment guidelines, and those crucial clinical pearls that separate a good nurse practitioner from a great one. This isn't just about passing a test, it's about building the confidence to handle these complex cases with skill and compassion. So, grab your notebook, get comfortable, and let's master this neurology review together. Let's get into it. Alright, let's start with a condition that can be really alarming for patients. Bell's palsy. This is an acute unilateral facial paralysis, and it comes on fast. We're talking hours to a couple of days. The cause is idiopathic, meaning we don't know the exact trigger, but it's strongly associated with the reactivation of a latent herpes simplex virus, leading to inflammation and swelling of the facial nerve, which is cranial nerve 7. When a patient walks in with one side of their face drooping, your first job is to stay calm and help them stay calm, because their first thought is often, "Am I having a stroke?" This brings us to the most critical diagnostic step, differentiating Bell's palsy from a stroke. This is a huge FNP exam pearl. In Bell's palsy, the paralysis affects the entire side of the face, including the forehead. The patient won't be able to wrinkle their forehead or raise their eyebrow on the affected side. In a stroke, especially an ischemic one, the forehead is typically spared. This is because the forehead muscles receive nerve signals from both hemispheres of the brain. So if you ask the patient to raise their eyebrows and the forehead moves symmetrically, you need to be thinking stroke, not Bell's. That's a red flag. The diagnosis of Bell's palsy is primarily clinical. You take a thorough history, you do your neuro exam, paying close attention to that forehead muscle. You don't typically need imaging like a CT or MRI unless the presentation is atypical, or there are other neurological signs that suggest something more sinister is going on. For example, if the weakness is progressing beyond 3 weeks, or if other cranial nerves are involved, that's when you might consider imaging to rule out a tumor or other structural lesion pressing on the nerve. When it comes to treatment, time is of the essence. The standard of care is a short course of high-dose oral corticosteroids, like prednisone. You want to start this within 72 hours of symptom onset for the best chance of a full recovery. The evidence shows it reduces nerve inflammation and improves outcomes. You're giving these patients a powerful anti-inflammatory to calm that angry, swollen facial nerve down. Antivirals like acyclovir or valacyclovir are a bit more controversial. Some guidelines recommend adding them to the steroid regimen, especially in cases of severe facial palsy, based on the theory of HSV reactivation. However, the evidence for their added benefit isn't as strong as it is for steroids. For your exam, know that steroids are the mainstay, and antivirals are often considered as an adjunct therapy, but the key is starting that prednisone as soon as possible. A huge part of managing Bell's palsy is supportive care, and this is where your patient education really shines. The biggest risk is corneal injury because the patient can't blink properly on the affected side. This leads to dry eye or exposure keratitis. You need to counsel them on media group person applying lubricating eye drops, patient using artificial tears, pharmacist demonstrating eye drop use at stock at distribute_equally, using lubricating eye drops throughout the day, wearing protective glasses when they're outside, and taping the eye shut at night. This isn't just a suggestion, it's essential to prevent permanent eye damage. Finally, let's talk prognosis and pearls. The good news is that for most people, the prognosis is excellent. Over 70% of patients have a complete recovery within 6 months, even without treatment, but steroids significantly improve those odds. A key pearl is to reassure your patient. They're often distressed about their appearance and the suddenness of it all. Explaining the typical course of the illness, emphasizing the high likelihood of recovery, and providing that crucial eye care education is just as important as writing the prescription. Moving on to a topic that touches so many families, dementia. This isn't a single disease but an umbrella term for a decline in cognitive function that's severe enough to interfere with daily life. It's progressive and unfortunately incurable. As a primary care FNP, you'll be on the front lines of identifying, diagnosing, and managing these patients. The most common type, as we all know, is Alzheimer's disease, accounting for the majority of cases, but it's crucial to remember other types like vascular dementia, Lewy body dementia, and frontotemporal dementia. The diagnostic process for dementia is a marathon, not a sprint. It starts with listening. A family member often brings the patient in saying, "Mom just isn't herself." They'll talk about memory loss, especially for recent events, confusion, personality changes, or difficulty with tasks they used to do easily, like managing finances. Your job is to gather this collateral information, as the patient may lack insight into their own deficits. This history is the cornerstone of your diagnosis. Next up are the screening tools. The Mini Mental State Exam and the Montreal Cognitive Assessment are your go-to instruments. The MoCA is generally considered more sensitive for mild cognitive impairment, which can be a precursor to dementia. These aren't just pass or fail tests. They give you a quantifiable baseline and help identify specific cognitive domains that are affected, like memory, attention, or executive function. Remember to document the score so you can track changes over time. Once you suspect dementia based on history and cognitive screening, you have to do your due diligence to rule out reversible causes. This is a massive FNP board topic. You need to order a standard panel of labs, ACBC, CMP, TSH, and a vitamin B12 level. Hypothyroidism and B12 deficiency can both present with cognitive symptoms that mimic dementia, but they are treatable. You also need to review their medication list carefully. Anticholinergics, benzodiazepines, and opioids are common culprits for causing confusion, especially in the elderly. In terms of treatment, we have to be realistic with patients and families. There is no cure. The medications we have, like cholinesterase inhibitors, donepezil, rivastigmine, and NMDA receptor antagonists, memantine, can offer modest symptomatic benefit. They might slow the progression of symptoms for a period of 6 months to a year, but they don't stop the underlying disease process. The goal of treatment is to maximize function and quality of life for as long as possible. A huge part of management is non-pharmacological. This is where the art of nursing comes in. It's about creating a safe environment, establishing routines, managing behavioral symptoms without immediately reaching for antipsychotics, and providing caregiver support. Caregiver burnout is a real and serious complication. Connecting the family with resources like the Alzheimer's Association, support groups, and adult daycare can be the single most impactful thing you do for that family unit. Here are your clinical pearls. First, always screen for depression. Depression can cause what we call pseudodementia, a cognitive decline that looks like dementia but is actually due to a mood disorder. Treat the depression, and the cognition often improves. Second, when behavioral issues arise, like agitation or aggression, think pain, infection, or constipation first. An elderly person with dementia may not be able to tell you they have a urinary tract infection or are in pain, and it will manifest as a behavioral change. Look for a reversible cause before labeling it as part of the disease. Let's talk about one of the most common complaints you will ever see in primary care: headaches. The sheer volume can be overwhelming, but your job is to be a detective, to sort through the benign, common types and, most importantly, not miss the dangerous ones. The vast majority will be primary headaches, meaning the headache itself is the problem. We're talking tension type, migraine, and cluster headaches. Differentiating these is all about the history. Tension type headaches are the most common. Patients describe them as a dull, aching, non-pulsating pain, often like a tight band around the head, bilateral. They're not usually associated with nausea, vomiting, or sensitivity to light and sound. They can be episodic or chronic, and they're often related to stress, poor posture, or muscle tension in the neck and shoulders. Management is typically straightforward with over-the-counter analgesics like acetaminophen or NSAIDs, along with lifestyle modifications like stress reduction and physical therapy. Migraines are a different beast entirely. These are typically unilateral, pulsating, and moderate to severe in intensity. The key features that point you toward migraine are the associated symptoms: nausea, vomiting, photophobia, light sensitivity, and phonophobia, sound sensitivity. About a third of migraine sufferers experience an aura, transient neurological symptoms, most often visual, like seeing flashing lights or zigzag lines that precede or accompany the headache. This is a classic board question. Know the difference between migraine with and without aura. Treatment for migraines is two-pronged: abortive and prophylactic. Abortive therapy is for treating an acute attack. For mild to moderate migraines, NSAIDs can work. For more severe attacks, the triptans, like sumatriptan, are the first-line therapy. They are serotonin receptor agonists that work by causing vasoconstriction. Prophylactic therapy is used to reduce the frequency of attacks in patients who have frequent or debilitating migraines. Options here are broad and include beta blockers, propranolol, antidepressants, amitriptyline, and anticonvulsants, topiramate. Then you have cluster headaches. These are less common but incredibly severe. They're known as suicide headaches for a reason. The pain is excruciating, unilateral, and located in or around the eye or temple. It's associated with ipsilateral autonomic symptoms: a stuffy or runny nose, tearing, eye redness, or a droopy eyelid on the same side as the pain. The attacks occur in clusters, meaning they happen daily for weeks or months, and then go into remission. The classic patient profile is a middle-aged male smoker. The acute treatment for a cluster headache is unique. 100% high-flow oxygen via a non-rebreather mask is the first-line therapy. It can provide rapid relief. Subcutaneous sumatriptan is also highly effective. For prevention during a cluster period, verapamil, a calcium channel blocker, is the drug of choice. It's crucial to get these patients on preventive therapy quickly to break the cycle of attacks. Now for the most important part, the red flags. You need to have the SNOOP mnemonic burned into your brain. S for systemic symptoms: fever, weight loss. N for neurologic signs: confusion, focal deficits. O for onset: sudden thunderclap headache. O for older age: new onset headache in a patient over 50. And P for pattern change: a change in the frequency or severity of their usual headaches. Any of these should trigger an immediate, thorough workup, usually including neuroimaging, to rule out a secondary cause like a subarachnoid hemorrhage, meningitis, or a brain tumor. Missing a red flag headache can be catastrophic. Parkinson's disease is, a progressive neurodegenerative disorder that primarily affects dopamine-producing neurons in a specific area of the brain called the substantia nigra. The loss of dopamine leads to the classic motor symptoms that we all learn about. As an FNP, you may actually be the first to notice the subtle early signs, long before the patient presents with a significant tremor. These can include a reduced sense of smell, which we call anosmia, constipation, sleep disturbances, or even just a general slowing down. The diagnosis of Parkinson's is clinical, and it really rests on identifying the cardinal motor features. The mnemonic trap is your best friend here. T for tremor, specifically a resting tremor. It's often described as pill rolling, and interestingly, it gets better with voluntary movement. R stands for rigidity, a stiffness or resistance to passive movement. You can feel this as cogwheel or lead pipe rigidity when you move the patient's limbs. A is for akinesia or bradykinesia, which means slowness of movement. This is often the most disabling symptom: difficulty initiating movement, a shuffling gait, and a masked, expressionless face, also known as hypomimia. P is for postural instability, which leads to imbalance and falls, but this is typically a later sign. To make a clinical diagnosis, you need bradykinesia plus at least one of the other two main features: tremor or rigidity. It's also critical to note that the symptoms are typically asymmetric at onset. They start on one side of the body. If a patient presents with perfectly symmetrical Parkinsonian symptoms from the get-go, you should question the diagnosis and consider other causes like drug-induced Parkinsonism or other atypical Parkinsonian syndromes. When it comes to treatment, we're again focused on symptom management, not a cure. The goal is to replace or mimic the effects of dopamine. The gold standard and most effective medication is levodopa, usually combined with carbidopa, as in Sinemet. Carbidopa prevents the breakdown of levodopa in the periphery, allowing more of it to get to the brain where it's needed, and also reducing side effects like nausea. Starting levodopa is a big decision, and the timing is often debated. There's a concern that starting levodopa too early can lead to the earlier development of motor complications, like dyskinesias, which are involuntary writhing movements, and on-off fluctuations, where the medication's effect wears off unpredictably. Because of this, in younger patients with milder symptoms, we often start with other classes of drugs first. These include dopamine agonists like pramipexole or ropinirole, or MAOB inhibitors like selegiline or rasagiline. These are less potent than levodopa, but can provide good symptom control early on and delay the need for levodopa. Beyond medications, a multidisciplinary approach is, honestly, essential. Physical therapy is crucial for gait and balance training to prevent falls. Occupational therapy helps with adapting daily activities. Speech therapy is important for both speech volume, which we call hypophonia, and swallowing difficulties, or dysphagia, which can lead to aspiration pneumonia. Your role as the FNP is often to be the coordinator of this care team. For your clinical pearls. First, remember that not all tremors are Parkinson's. An essential tremor is actually much more common. The key difference is that an essential tremor is an action tremor. It's worse with movement, like trying to drink from a glass, and gets better with rest. A Parkinsonian tremor is a resting tremor. Second, be aware of the non-motor symptoms. Depression, anxiety, and cognitive impairment are extremely common in Parkinson's and have a huge impact on quality of life. Always screen for and treat these comorbidities. This is one of the most time-sensitive and critical topics in all of medicine: stroke and transient ischemic attack, or TIA. A stroke, also known as a cerebrovascular accident, happens when blood flow to a part of the brain is interrupted, leading to brain cell death. A TIA is often called a mini-stroke. It's a temporary blockage where the symptoms resolve completely, usually within an hour and always within 24 hours, without causing permanent damage. But a TIA is a massive warning sign. Up to a third of people who have a TIA will go on to have a major stroke. The number one thing you need to drill into your head for the exam and for practice is recognizing the signs of a stroke. The B-FAST acronym is the standard. B stands for balance loss, E for eyes or vision changes, F for face drooping, A for arm weakness, S for speech difficulty, and T for time to call 911. Any sudden onset of these symptoms is a medical emergency. As a primary care provider, if a patient calls your office describing these symptoms, the instruction is unequivocal. Hang up and call 911 immediately. Do not have them drive to your office or an urgent care. There are two main types of stroke: ischemic and hemorrhagic. Ischemic strokes caused by a clot blocking a blood vessel are the most common, accounting for about 85% of all strokes. Hemorrhagic strokes are caused by a ruptured blood vessel bleeding into the brain. The initial symptoms can look identical, but the management is completely different. That's why the first and most important step when a patient arrives at the emergency department is a non-contrast CT scan of the head. The purpose of that initial CT scan is not to see the ischemic stroke, because an infarct might not be visible for hours, but to rule out a bleed. If there's no blood on the CT, we can proceed with treatment for an ischemic stroke. If there is blood, the patient has a hemorrhagic stroke, and giving them clot-busting medication would be fatal. This is a critical decision point. For an acute ischemic stroke, the mantra is time is brain. If the patient is an eligible candidate, the goal is to give thrombolytic therapy with alteplase, also known as TPA. This is a powerful clot-busting drug that can restore blood flow and reverse or minimize the stroke's effects. But there is a very strict time window, typically within 3 to 4.5 hours of the last known well time. There's also a long list of contraindications, like recent surgery, bleeding disorders, or uncontrolled hypertension, that you need to be aware of. For patients who are outside the TPA window or have a large vessel occlusion, mechanical thrombectomy is an option. This is a procedure where an interventional radiologist threads a catheter up to the brain and physically pulls the clot out. This has really revolutionized stroke care for eligible patients. For a TIA or a patient who is not a TPA candidate, the immediate treatment is antiplatelet therapy, usually aspirin. The long-term management after a stroke or TIA is all about secondary prevention. This is where the primary care FNP takes over. It involves aggressive management of risk factors. This means controlling blood pressure, managing cholesterol with high-intensity statins, ensuring diabetes control, and counseling on smoking cessation. Antiplatelet therapy, like aspirin, clopidogrel, or a combination, is standard to prevent another clot from forming. For strokes caused by atrial fibrillation, anticoagulation, like warfarin or a DOAC, is necessary. Rehabilitation with physical therapy, occupational therapy, and speech therapy is also a cornerstone of recovery. Temporal arteritis, also known as giant cell arteritis or GCA, is a condition you absolutely cannot afford to miss. This is a systemic vasculitis, an inflammation of the lining of medium and large arteries. While it can affect any large artery, it has a classic predilection for the branches of the carotid artery, especially the temporal artery. This is a disease of the elderly. It's extremely rare in people under 50. The average age of onset is around 75. The classic presentation that you need to know for your exam is a new onset headache in a patient over 50. This isn't just any headache. It's typically localized to the temporal or frontal area, and patients might describe it as a dull, boring pain or a burning sensation. A key feature is scalp tenderness. Patients might complain that it hurts to brush their hair, wear a hat, or rest their head on a pillow. This symptom is highly suggestive of GCA. Another hallmark symptom is jaw claudication. This is pain or fatigue in the jaw muscles with chewing, which resolves with rest. Think of it as angina of the jaw. The inflammation in the arteries is restricting blood flow to the masseter muscles, causing ischemic pain when they're being used. When a patient over 50 complains of a new headache and jaw pain with chewing, your suspicion for GCA should be sky high. The most feared complication of GCA, and the reason it's a medical emergency, is vision loss. The vasculitis can affect the ophthalmic artery, leading to a condition called anterior ischemic optic neuropathy, or AION. This causes sudden, painless, and often permanent blindness in one eye. If treatment is not started immediately, it can progress to the other eye within days or weeks. Any patient you suspect has GCA who complains of any visual symptoms, blurriness, double vision, or transient vision loss, also called amaurosis fugax, needs to be sent to the emergency department immediately. The diagnosis is supported by lab work. The hallmark lab finding is a markedly elevated erythrocyte sedimentation rate, often over 100 millimeters per hour. The C-reactive protein will also be highly elevated. These are non-specific markers of inflammation, but in the right clinical context, a very high ESR is strong evidence for GCA. You should also know that GCA is very closely associated with another condition called polymyalgia rheumatica, or PMR, which causes pain and stiffness in the shoulders and hips. The definitive diagnosis is made by a temporal artery biopsy. A surgeon removes a small piece of the temporal artery, and a pathologist looks for characteristic signs of inflammation, including the giant cells that give the disease its name. However, you should never, ever wait for the biopsy result to start treatment. The mantra is biopsy, but treat first. The risk of vision loss is too great to delay therapy. Treatment is high-dose systemic corticosteroids, typically prednisone at a dose of 1 milligram per kilogram per day, usually 40 to 60 milligrams daily. You start this immediately based on your clinical suspicion. The steroids dramatically reduce the inflammation and can prevent blindness. Patients often feel remarkably better within a day or two of starting treatment. The steroids are then tapered very slowly over 1 to 2 years. Because of the long duration of high-dose steroid use, you also have to manage the side effects, including initiating bone protection with calcium, vitamin D, and possibly a bisphosphonate. Let's wrap up with another incredibly painful condition, trigeminal neuralgia, also known as tic douloureux. This is a chronic pain disorder affecting the trigeminal nerve or cranial nerve 5, which is responsible for sensation in the face. It's characterized by episodes of intense, stabbing, electric shock-like pain in the areas supplied by one or more branches of the trigeminal nerve, the forehead, cheek, or jaw. The pain is almost always unilateral. The key feature of this pain is its paroxysmal nature. It comes in sudden, brief attacks that last from a few seconds to a couple of minutes. These attacks can occur in quick succession, lasting for hours. Between the episodes, the patient is typically pain-free. This episodic pattern is a crucial diagnostic clue. The pain is so severe that it can be physically and emotionally incapacitating. Patients often live in fear of the next attack. What makes trigeminal neuralgia particularly challenging is that the attacks are often triggered by normal, everyday stimuli. Things like touching the face, washing, shaving, brushing teeth, eating, drinking, or even a cool breeze can set off an excruciating jolt of pain. Patients may develop behaviors to avoid these triggers, such as not washing one side of their face or avoiding food that requires chewing. This can often lead to weight loss and poor hygiene. The diagnosis is almost entirely clinical, based on the characteristic history. You're listening for that description of unilateral electric shock-like pain that is brief, paroxysmal, and has specific triggers. The neurological exam is typically normal. There shouldn't be any sensory loss in the trigeminal distribution between attacks. If you find sensory loss, facial weakness, or other neurological deficits, this is a red flag for a secondary cause, like a brain tumor or multiple sclerosis, and requires an MRI of the brain. The most common cause of classic trigeminal neuralgia is thought to be neurovascular compression, where a blood vessel, usually an artery, is pressing on the trigeminal nerve at its root entry zone in the brainstem. This compression is believed to damage the myelin sheath of the nerve, causing it to fire erratically and generate these pain signals. An MRI or MRA, that's a magnetic resonance angiogram, can sometimes visualize this compression. When it comes to treatment, standard painkillers like NSAIDs or opioids are not effective for this type of neuropathic pain. The first-line medication and the drug of choice for your FNP exam is the anticonvulsant carbamazepine, also known as Tegretol. It works by stabilizing the hyperexcitable nerve membranes and is effective in a majority of patients. You start with a low dose and titrate up until the pain is controlled. You have to monitor for side effects, including drowsiness, dizziness, and importantly, you need to check a CBC due to the rare but serious risk of a granulocytosis and aplastic anemia. If carbamazepine is not tolerated or is ineffective, other medications can be tried, such as oxcarbazepine, a relative of carbamazepine with a better side effect profile, baclofen, lamotrigine, or gabapentin. For patients with refractory pain who don't respond to medications, surgical options can be considered. These range from microvascular decompression, where a surgeon places a small sponge between the compressing vessel and the nerve, to various ablative procedures that intentionally damage the nerve to stop the pain signals. And that's a wrap on our whirlwind tour of some high-yield neurology topics for your FNP exam. We've covered a lot of ground, from the facial droop of Bell's palsy to the debilitating pain of trigeminal neuralgia. Remember, the key to mastering this material is understanding the why behind the symptoms and treatments. Why does a stroke spare the forehead, but Bell's palsy doesn't? Why are steroids the go-to for temporal arteritis? Connecting these dots is what will make the information stick. As you continue your studies, I really want you to focus on solidifying your neurological exam skills. Go back and review the cranial nerves until you know them inside and out, not just their names, but their functions and how to test them. Being able to perform and interpret a confident neuro exam is not just for the test. It's a fundamental skill that will serve you every single day in your practice. It's your best tool for differentiating the benign from the life-threatening. This video is a starting point, a framework for your review. Don't stop here. Dive into your textbooks, use question banks, and seek out other great resources to build on this foundation. The journey to becoming a family nurse practitioner is a marathon, but you have the dedication and the ability to get there. Thank you so much for studying with me today. Be sure to hit that like and subscribe button for more content to help you succeed. Stay curious, and I'll see you in the next video.